Hello, hello, hello. Thank you everybody for joining us for our impactful discussion today on Black maternal health. It takes a village. My name is Saina Budiniznya. I am the new coordinator of the Linn Benton Health Equity Alliance, which essentially is a group of various organizations, community members, and stakeholders with the aim to elevate community needs and voices, specifically those who have been marginalized as a result of discriminatory systems of oppression. I am super excited to introduce our amazing facilitator for this evening's panel, Kimberly Porter. Kimberly Porter has a dual degree, Bachelor of Arts in Psychology and Sociology from Kent State University and a Master's of Clinical Social Work degree from the University of Michigan, Ann Arbor, where she graduated magna cum laude. She also has a postmaster's certifications in infant, toddler mental health and perinatal mood disorders, and is an adjunct professor at the Portland State University's Graduate School of Education. Kimberly is also a certified labor and postpartum doula and childbirth parent educator who has been dedicated, passionate, and proven leader in reducing infant and maternal mortality rates in Portland's Black community. She began her doula experience in 2014 and received her training with the South African Blessed Ways Doulas, International Center for Traditional Childbearing and Birthing Way College of Midwifery. She is an activist for social and reproductive justice and a voice for the African American women improving their birth outcomes and reducing pregnancy and birth-related health disparities in Oregon. She was the visionary for the Sacred Roots community-based doula program at the Black Parent Initiative, which provides holistic, cultural-specific, full-circle doula services to African-American families in the Portland and surrounding areas. Kimberly also serves on 3 boards: the Oregon Doula Association Board of Directors as the Diverse Communities Chair, Northwest Area Childbirth Educators Forum, and the Oregon Infant Mental Health Association General Member, with a focus on racial equity, culture, and diversity initiatives. She is committed to diversifying the doula profession and expanding doula services to communities of color in the state of Oregon. Kimberly facilitated the Oregon Doula Summit in 2019, and we are so honored and blessed to have her with us today. So please join me in virtually welcoming Kimberly Porter to the stage.
Thank you, everyone. It's an honor to be here to talk about Black maternal health. So we're going to have an exciting evening of thought-provoking, educational content and information. But I wanted to first start off by giving a moment of silence to honor Daunte Wright. Daunte Wright, on April the 11th, which was Sunday, was fatally shot in Brooklyn Center, Minnesota. It was about 10 miles where Derek Chauvin is on trial in the killing of George Floyd. I want to take this opportunity to give 2 minutes of silence in honor of his life. Thank you for taking this time to honor Dante Wright's life. Now I want to take an opportunity to kind of give you some an overview of kind of what tonight's going to look like. And so, just as Sunny said, we're going to have a very comprehensive overview of Black maternal health. We're going to look at it from a global, a national, and a local lens. And we're going to have a panelist. And so what I want to do first is to give you we're going to show you a video to give you some context and understanding as to why this issue is so important, and it's a public health issue. So I wanted to show a video about Kira Johnson. Kira Johnson died from complications of a scheduled C-section at Cedars-Sinai Medical Center shortly after giving birth to her second son. Her husband, Charles Johnson, is in this video, and he talks about the significance of her story. This case pushed in state and federal law to protect more women from pregnancy-related deaths. I just wanted to let you all know, trigger warning, this video will definitely be a tearjerker, and it definitely is going to get to the your heart of your soul.
So, mommy, where you at?
Beautiful Palm Springs. Daddy surprised me, and it's amazing.
So let's talk about this woman who is Kira Dixon Johnson. We're talking about a woman who was far better than I ever deserved and made me far better than I ever thought I could be. We're talking about a woman that raced cars, who ran marathons, who had her pilot's license. Talking about a woman who spoke 4 languages fluently and who taught me so much, not only about myself, how to be a father, but just about love. We walked into Cedars-Sinai Medical Center with Kira on April 12th of 2016 with a woman that was not just in good health, she was in exceptional health.
Hey, Mommy.
Hey, Daddy.
Hey, Winston.
Hey.
She went in for the procedure. Shortly after that, we were taken to delivery. God blessed us with another substantially, amazingly healthy, beautiful baby boy. Shortly after that, Kira sitting in the bedside, and I began to notice blood in the catheter. I alerted the nurses and the medical staff. They came to her attention. They examined her. They did several things. They ordered a series of tests of blood work. Around 4 o'clock, they ordered the CT scan that was supposed to be ordered stat, and I understood that to mean immediately. I was concerned, but at that time, I understood that there was a plan, and I could live with that. 4 o'clock comes. 5 o'clock comes, still no CT scan. 6 o'clock comes, they perform an ultrasound. They see that her abdomen is filling with fluid. Her blood work comes back. It shows that her blood levels are dropping. She's beginning to lose color. She's shivering uncontrollably. When they examine her, she's sensitive to the touch. So by 5:30, 6 o'clock, there were very clear signs that she was hemorrhaging internally significantly. 7 o'clock comes, still no CT scan. 8 o'clock comes. I'm begging, I'm pleading. My family is advocating for my wife. Still no scan. 9 o'clock comes, they say that they need to do a blood transfusion. And I ask and I'm begging again, do something. Where's this CT scan? I thought it was supposed to be performed stat hours ago. At which point the staff at Cedars-Sinai Medical Center tells me that your wife isn't a priority right now. 10 o'clock comes, still no scan. 11 o'clock comes. It was not until after midnight that they finally took Kira back to the OR. As we left the recovery room and walked down that hall to the OR, and I'm holding Kira's hand and she's telling me, baby, I'm scared. And I'm doing everything in my power to just remain calm and tell her everything's gonna be okay. The doctor says to me, I'm gonna go back in through the same incision I made. She'll be back in 15 minutes. And that was the last time I saw my wife alive. When they took her back into the OR, they opened her up and there were 3.5 liters of blood in her abdomen. And she coded immediately. Kira deserved better. My sons deserved better. Women all over this country deserve better. And I'm not here to tell you what I think, I'm here to tell you what I know. And there's people that are far more intelligent than I will ever be that focus on the data and the statistics, and you can look up and they're horrifying. What I'm here to tell you is that there's no statistic that can quantify what it's like to tell an 18-month-old that his mother's never coming home. There's no matrices that can begin to analyze the impact and how difficult it is to try and explain to a child that never will ever know his mother just how amazing she was. And so that's why we are here, because this is there's nothing that I can do to bring Kira back. There's nothing that I can do, but what I can do, and the highest honor and tribute that I can pay to my wife, is to fight as hard as I possibly can, whenever I can, to make sure that we send mothers home with their babies. So that being said, all of you wonderful, powerful advocates and healthcare workers and families who are fighting this fight with us, we love you and we thank you. And here's the good news. Change is coming. Change is coming. Feel free to take a more diplomatic approach if you please. But when I go to Capitol Hill tomorrow and Tuesday, and I sit down and I look these senators and congressmen and staffers in their eyes, I'm not here asking, I'm not here for a photo op. I am respectfully demanding that you support H.R. 1318. I'm respectfully demanding that you stand in opposition of further cuts to health care and Medicaid and Medicare. Our time is now. March for Moms, I thank you. We love you. For Kira, for moms. Kira, I love you forever.
Clap, clap, yay, give me hugs. Oh, I love you, Snake Eyes, you're my goodness. I love you. Okay, go press the button. I hope this is forever. I know this is forever. Okay, go press the button and come give me lovey.
Every time I watch this video, it just tears another piece of my heart. And I just want to reiterate the words of Charles Johnson. This is why we're here. This is why we're here. This is why we're here today. Because this cannot continue. And the African American maternal mortality and morbidity rate in this country has to stop. And we have come together today to be able to talk about this issue from a global, from a national, and a local lens. And I just wanted to take this opportunity to say that this is why we're here, and we must do better as a country to be able to mobilize, to come together as a community, to be able to change these birth outcomes and these maternal outcomes for African American women in the United States. Right now, I want to take an opportunity to introduce you to Sainabo Denise Nyong. Sainabo Denise Nyong is the new Linn Benton Health Equity Alliance Coordinator. Most of her academic and professional experience focuses on psychological and public health implications of discrimination in many marginalized communities, namely Black, Indigenous, people of color, BIPOC. Working at a Black-led gynecological and abortion clinic in Atlanta, Sainable has led organizational and coalition efforts in reducing the effects of discrimination on the BIPOC reproductive health and overall well-being, especially Black birthing persons. After graduating with a Master's in Public Health and Global Health and Community Health and Development from Emory University, empowering communities to build a sustained equity among marginalized communities through community-based healing is a crux of her professional and personal pursuits. I introduce Sinebo.
Thank you so much for that wonderful introduction, Kimberly. And just like you said, that video always has a way of tugging at my heartstrings, even though unfortunately this is a reality that a lot of us have understood before. So I am super honored to be able to share more information about the global context of Black maternal health globally, nationally, and also locally as well. I'll also be using Black birthing persons or Black births in order to garner more inclusive conversation around Black pregnancy-related health as well. So we're just going to start off right off the bat and showing a really powerful figure from the World Health Organization, which does a really good job at displaying the disproportionate burden of maternal mortality across the globe. As you can see, the red and yellow zones demonstrate countries that experience the highest level of burden. And most of those countries are concentrated either in the continent of Africa or South Asia. Although the map is really startling, it ultimately draws attention to the global continuity that Black and Brown bodies continue to hold most of the burden of maternal mortality. So much so, only 58 of these countries, again, concentrated in Africa and South Asia, contribute to 91% of the global burden of maternal mortality, 82% of the global burden of neonatal mortality, which is death of newborns 4 weeks old or less, and 80% of the global burden of stillbirths. To put this into context, we have about 198 countries in the world. Only a quarter of them make 91% of the global burden of maternal mortality. I'm not so great with math, but it's just not adding up to me. And it's no secret the ways in which colonialism, neo-colonialism, white supremacy, and racism has played a role in this. So much so that only 83% of birthing providers, such as midwives, nurses, and physicians, are concentrated in the West. So ultimately, it's these systems of oppression that permeates through global borders and burdens the homes of these Black and Brown birthing persons. You can hit the next slide. So with that being said, there's a question of, if most birthing providers are concentrated in the West, like the United States, why are Black birthing persons living in the United States still at a higher risk of complications or death related to childbirth? In the next slide, we cover the national and local context of Black maternal health. Now, the answer to that question, unfortunately, is multifold. In the United States, as we all know, our healthcare system is for profit, which means your access to care is dependent on how much money you have and not dependent on the need that you display. The US spends about $110 billion towards healthcare costs, but still is ranked one of the lowest in birth outcomes. So this idea of high cost and high cost outcomes for seeking healthcare services ultimately leads to low birth outcomes and then creating a hierarchy of prioritizing some lives over others. Those lives being prioritized are often white and wealthy. Then we introduce this concept of too much too soon, too little too late, which speaks to how some medical interventions that happen too early, like C-sections, that are taxing to the body and ultimately driving maternal mortality, but fundamentally disrespect the birthing person's bodies and agency, very little sources and little care for their needs. Black women, on average, enter pregnancy less healthy compared to other women. And when we say healthy, we're talking about access to prenatal vitamins, folic acid, that we all know is very important to the healthy development of a fetus. Services like prenatal services that monitor the mother's health over the course of their pregnancy. Black women are also most likely to lose their Medicaid during pregnancy. As we know, Medicaid, you do qualify for Medicaid if you are pregnant. But for some Black women, they don't have that access anymore. So that introduced this concept of variable and low quality care, which can also be a product of environmental racism, where areas that are heavily populated by people of color, namely Black folks, are usually areas that have been historically redlined, resulting in food deserts or food insecure spaces, living near manufacturing plants that either pollute our air, our water, our food, or even living in areas that are heavily policed that can substantially increase stress in these folks. And we all know stress is something that we try to avoid among pregnant folks. To this effect, we talk about how midwives have shown to demonstrate a level of support and care that has better health outcomes for Black birthing persons. But truth be told, only 11% of Black births are attended by midwives. Studies have also shown that providers, when providers and babies are a cultural match, which means if the baby is Black, and the provider is Black, babies have a higher chance of surviving birth than if the baby and the provider are not matches. A simple match of having diverse care, of having a midwife, a nurse, or a doctor that looks like you, to know that that is an indicator of whether or not your baby survives childbirth is a little bit startling. But ultimately, we can talk about the relationship between a lack of diverse birthing staff for birthing persons, but all of this is truly a result of rampant inequality, structural racism, which prevents any political will for implementing laws, policies, and best practices to eliminate such burden on our Black birthing persons. In the next slide, another great graph that talks about or demonstrates the effect of structural racism and inequality on maternal deaths. This graph shows that how the US has been and continues to be on the rise of overall maternal deaths. Compared to other high resource regions, the US almost doubles the rate of maternal death. And honestly, it's making the US a moniker of failing our birthing persons here, mainly Black birthing persons here. In the next slide, now we are looking at pregnancy-related deaths across racial groups. We see a staggering increase among Black and American Indian Alaska Natives over the years. Disparities also exist in maternal and infant mortality rates by geographic location. In 2016, more than 5 million women lived in the counties, either rural or urban, with neither an OBGYN, midwife, or a hospital with a maternity unit. So in these rural areas, maternal mortality rates was about 2.94 per every 100,000 live births, compared to metropolitan cities, which is roughly about 18.2. We see similar trends in infant mortality rates where it's 20% higher than in large urban counties. Because of this, the generation, meaning our mothers and parents, are more likely to die of childbirth than the generation from our parents and our grandparents. The next slide, we look at the similar trends across infant, neonatal, and postnatal mortality rates, as we did in our last slide on maternal mortality. This demonstrates that Black and American Indian, Alaskan Native, and Native Hawaiians and other Pacific Islanders are more likely to experience infant-related death. Because the only indicator, the only difference between these babies is simply their racial identity. Now we can get into the conversation of access to care and matching doulas and matching providers, but to know that your racial identity is a source of an implicit bias that can cost either you or the parent's life is ultimately heart-wrenching, as we see in Kira's case. Now, with that, when we're talking about how this generation is most likely to suffer from both maternal and infant death related to pregnancy-related outcomes, we're ultimately talking about the ways in which maternal health or reproductive health can negatively impact our communal health. So with this, we really truly believe that maternal health is community health. Without that, we cannot support our community, we cannot invest in our community, and we cannot build our community either. This slide does a really good job of showing the relationship between social determinants of health in relation to system level risk factors. Social determinants of health are mutable upstream factors that influence health, such as housing instability, transportation, and employment. this wonderful image from the Institute of Clinical Systems Improvement breaks this down for us, breaks down the effects of detriments of health, suggesting that the fully half of a person's health is determined by socioeconomic factors such as their education, their job status, social support, income, and community safety, combined with the aspects of a physical environment in which one lives in. To the earlier point about environmental racism, 50% of a person's health and well-being is determined by their zip code. 50% of a person's health and well-being is determined by their zip code, not their health behavior, not their access to care. So this really does talk about the ways in which environmental racism is ultimately hurting our people, is hurting our community. Only about 30% can be attributed to an individual health behavior, and a mere 20% to the health care that the person receives. And even within that 30% of health behaviors, we need to talk about how health behaviors are often a product of socioeconomic factors and a physical environment. Like some persons may have a higher risk or a higher chance of engaging tobacco products simply because that they have an easier access to tobacco products in the areas versus, I don't know, maybe healthy food. So even if behaviors are indicative of the environment, it has to be taken within a context that these behaviors are a result of what's available in the environment of which this person lives in. Social determinants of health sits between the structural inequities and the policy aspects of health system, as it demonstrates an interactive relationship between macro, micro, and interpersonal systems that contribute to the larger issue of risk factors. So we've talked about pregnancy-related maternal mortality globally and nationally, but the question begs, what does that look like in our own region? Here, this pie graph demonstrates overall births in Oregon by race and ethnicity, which clearly shows an overwhelming rate of white babies at 70%, where Black babies are at 2.8, and American Indian Alaskan Natives are roughly about 1.3. With that, data around maternal mortality by race is not as diverse as we see here. Most data is situated within a context of white, non-white / BIPOC framework. So with that, it uses white babies and white birthing persons as a norm baseline, thus othering Black and Indigenous communities. That simple tactic of looking at white people as a standard is ultimately otherizing Black persons from access to care and ultimately capturing them in our data. This makes it extremely difficult to observe these trends in birthing persons in our region by race and ethnicity. This is the gap that we are intending to fill with our panel. This is what birthed the need of today's conversation, as all of our panelists are wonderful and knowledgeable to not only the topic at hand, but also how it looks like in our local area, and can speak to the contextual awareness and knowledge to what it looks like here in Linn, Benton, and Lincoln counties. So with that, I really close this presentation affirming and agreeing with everybody that this is really scary. It's gut-wrenching information that may be news to others and may not be news to other people, but it's information that identifies a need to approach a pregnancy-related mortality specifically for Black persons with a community health equity perspective. This is what birthed today's panel, which explores how healthy communities start with healthy births.
Thank you, Senebo. Thanks for that comprehensive overview of the data and statistics and some of the factors that are contributing to the infant and maternal mortality and morbidity rate, not only, like I said, in the United States, but locally as we sit in, Linn, Benton, and also in Oregon. As you all know, the theme of our, event tonight is It Takes a Village. And so I want to introduce you to some of our village members. And so I will introduce you to our panelists. We're going to have a roundtable discussion. Another one of our kind of themes is that we believe that healthy communities start with healthy pregnancies. And so we have mobilized a dynamic and brilliant team of Black African-American women that I'm so excited to be a part of as a person that's been part of Black maternal health for the last 30 years. This is really exciting to come together amongst my sisters to be able to have this conversation about Black maternal health. And so I want to introduce you to the village. So I'm going to go around and I'm going to just let you know who they are, and then we'll engage in this roundtable discussion. So I want to start off with Erica Bridget Vignoli. She holds a master's in public health from Oregon State University, where she focused on the development, implementation, and evaluation of culturally just maternal and child health programs. She also was the lead researcher on a qualitative study examining the root causes and solutions to the high preterm and low birth weight rates in Black communities, where she interviewed Black midwives from throughout the United States. Erica has worked as a community health worker, CHW community health worker supervisor, and program director and community organizer. She is currently the small grants fund manager at the Portland Children's Levy. Welcome, Erica. So next we have Deirdre Green. Deirdre Green is an adult nurse practitioner. She was recently appointed Chair Health and Wellness Committee of the NAACP Corvallis, Albany. She retired 1 year ago after 18 years of practice as a primary care provider at Samaritan Corvallis Internal Medicine Clinic. Deirdre Green states that she was put on earth to be a nurse. She knew she wanted to be a nurse, and at the age of 4 years old, and pursued and fulfilled her lifelong passion. Deirdre, a nurse for 43 years, practicing the last 20 years as an adult nurse practitioner and primary care clinician at Samaritan Corvallis Internal Medicine Clinic. Deirdre received a bachelor's in science in nursing at Hampton University in Hampton, Virginia. Yay, my mom went to Hampton. Yay, Hampton. You received an MS in critical care trauma nursing from University of California, San Francisco in 1994, and a postmaster's certificate in nursing practitioner degree from Oregon Health and Science. I want to next introduce Mikane Arifane. Mikane is a cultural organizer, consultant, and facilitator. She is a founding member of the Radical Imagination Collective and lead organizer of its annual gathering opening space for the Radical Imagination. She has received several awards for her cultural aware and equity-focused leadership. She is a doula with the Community Doula Program and a curriculum developer with Community College Democratizing Doula Training Project. She holds a master's degree in applied anthropology from Oregon State University, where she was instrumental in launching AYA Women of Color Initiative. She served as a vice president of the Black Graduate Student Association and vice president of social justice for the Coalition of Graduate Employees, the local 6069. Her graduate research was conducted with her community of women in northern Ethiopia, where she learned how they model, express, and reflect the values of community, trust, care, stability, and fertility through their perceptions and sentiments regarding social and political change. She enjoys her trips to Ethiopia, reading comic books and speculative fiction, long phone calls with friends and family, and spending time in the forest, river, and ocean. Wow, y'all some dynamic women out here. My goodness. Next, we have Nadia English Williams. Nadia English Williams is a naturopathic physician, midwife, and PhD student in applied medical anthropology at Oregon State University. Her research focuses on infant and maternal morbidity and mortality for Black women. Nadia maintains a full spectrum primary care practice with a focus on women's health, natural childbirth, and pediatrics. Her primary career objective is to abolish, I love the word, abolish, maternal and neonatal health disparities for women of color through three-tiered approaches. This includes eliminating inequities in healthcare access by influencing public policy, promoting seamless integration of midwives, obstetricians, and doulas for every birthing person, and aiding in the development of community obstetric standards to better address the covert and overt effects of institutional racism on Black birthing bodies. And then we also have Dr. Martinez. Dr. Martinez provides a full range of obstetrical and gynecological care to teen and adult women and performs both minor and major gynecological surgery. Examples of in-office procedures include endometrial ablation, coloscopy, and loop electrosurgical excision procedures. Examples of operating room procedures include C-sections, dilation and curation, laparoscopic hysterectomy, laparoscopic removal of tubes and ovaries, and diagnostic laparoscopy. She has more than a decade of experience as an OBGYN, caring for OBGYN patients, including the care and high-risk maternal patients. Dr. Martinez chose to join Samaritan Obstetrics and Gynecology because of the collaboration care offered there. Away from office, she enjoys reading, swimming, going on vacation, and spending time with her family. So I welcome this village of panelists. And so I would have some questions for each and every one of you all. And like I said, it's kind of going to be, it is a round table, but if anyone wants to, add to, ask specific questions to different people, you can join in as well. So it doesn't have to be so academic. This is, a conversation about our community. And so as a community, we're very relational. So just feel free to jump in. I want to start off with Erica. Erica, could you please share your experiences interviewing Black midwives across the U.S. and tell us a little bit about what you've learned from that experience, a little bit about your research? I really want to know, since we're talking about community, tell me about your community experience as it relates to Black maternal health and having more of a culturally just or culturally appropriate lens into care.
Okay. I guess I'll start with the last part first with my own experience. So when I first started kind of falling into the research about low birth weight and preterm birth in graduate school, I had already kind of come to it from a different background. For one, I'd had both of my children, and with the first one, I had gotten pregnant while I was actually in Kenya doing work with families over there in Kenya. I was working with widows and orphans. And so for my first trimester and a half, I was actually pregnant with my first child in Africa, in Kenya, and around some of the poorest women in that region of that low-income country. And what I saw there was just, endless suffering, really. And I really felt like there had to be ways to do maternal health that would have better outcomes in these kinds of communities, and they had to be rooted in culture. I just knew, like, coming in from the outside, I saw all kinds of people coming from Europe and the US and telling people what was good for them in their communities, and it wasn't working. And I knew from my own experience as a Black woman in the US that doesn't work. So I knew there had to be a different way. And that was part of what took me to graduate school and looking at what would be ways to have really culturally centered care. And while I was there, I started learning about the preterm birth rate and the low birth weight rate and how high they were in African American communities. And I guess I just hadn't really realized it before. It's not that I hadn't seen a lot of preemie babies. I guess I just hadn't compared it to other groups and how many preemie babies they were. It looked normal to me. It hadn't occurred to me all of the effects. And when I started reading about it and learning about all of the different medical disorders that are associated with low birth weight and preterm birth later in life, it was just like reading a description of everything that's described in our community. And so it just really hit me how important this was. And I wanted to have a way to tell the story that, again, was centered in culture and was centered in our history and was coming from a place of strength. Because if you are a Black person taking classes on maternal and child health and public health, I was the only African American identified student in most of my classes. And in every class, the case study of what was the biggest disparity was always the Black community. It didn't matter if it was cardiovascular care, if it was maternal care, whatever we were talking about, the case study is Black people. Yeah. And that sits with you. It gets heavy in your body to just constantly be hearing, like, what's wrong with your people, what's wrong with your community from people that don't look like you. even though there's this great intention to make things better. And to me, the most logical way to explore that story was to go to Black midwives, because Black midwives are themselves mostly women who have birthed to themselves. They've had their own children, they've raised their children, they've raised other people's, you know, their community children. They're part of our community. They have not been heard largely in the public health world. That voice is missing. The voice of midwives in general is missing, but the voice of Black midwives is missing in particular. And given the history of Black midwifery in this country as being so foundational, it felt really important to go to Black midwives and say, why do you think we have these rates of low birth weight and preterm birth in our community? What have you seen in your practice and in your own lived story that could lead to that? And what do you think the solutions are? And so I talked to 29 midwives across the country, elder midwives, student midwives, nurse midwives, licensed midwives, direct entry midwives, CPMs, all of the different types. And the unity behind what people said was what really struck me. So if you were to say to me, Kimberly, okay, I have a midwife who is from the Northeast, she's a nurse midwife, and she's been in practice 10 years. I could pretty closely predict what the themes of what she was gonna say were, because it was so consistent between those types. And the major themes for the causes that were identified was systemic racism, number one. Number two, what we call the epigenetic legacy of enslavement. So the ways that the experience of enslavement had both a genetic impact as well as an internalization of the trauma that gets passed on from one generation to another. And then ongoing cultural loss, by that I mean displacement, gentrification, becoming disconnected from your families in different kinds of ways that has happened as a result of systemic racism and all of the policies that have been imposed on our communities. But then I asked everyone, if I gave you an unlimited budget, you know, just here's a heap of money, how would you solve this problem? What it always came down to was culturally centered care, culturally matched care, strength-based care, having a place that people could come to where all the pictures on the wall look like someone like you, where you come in and you smell things cooking in the crock pot that are foods that are familiar to you, that make you feel comfortable. You hear music that makes you feel comfortable. Your sisters are welcoming you in. There's places to go to get resources. You know, maybe your partner is looking for a job, or you're looking for a job, or there's different things you need, but places to be in community where the community wraps around you and celebrates you. Those were the solutions that everyone identified in various different ways, regardless of what type of midwife they were. So that is really the key pieces to what happened in my study. I think did you ask me about the community health workers as well? Kim, are we getting to that later?
No, we can talk about that now, because I want to give some, and I also want to give Deidre an opportunity as well. But I really want to give some kind of context to our history, you know, in terms of the story of Black granny midwives, and really what that looks like, and how we can use some of that practice and some of that just way of caring for Black birthing people into today. And so, yes, I think you kind of talking a little bit about community health workers and what you're seeing and what your experience has been, why you became a community health worker, what does that look like in more Indigenous communities, just in general, just kind of like bring it back to like present time.
Okay, well, I really think that community health workers and in the Black community are a lot like the Black midwives, the elder midwives. They do things a lot in very similar way. The key difference being that they're not only focused on reproductive health, that it's more generalized. But And even elder Black midwives, granny midwives did more than just reproductive health, right? They were really the center of communities. But the community health workers are just trusted members of their own communities, people who have been identified already as leaders in their communities across a whole spectrum of different cultural communities, linguistic communities, sexual identity groups. All of them could have community health workers working in, and it's people from your community who are there to help you address most pressing health problems. And I became a community health worker, you know, I came in sort of the back door because of the work that I was doing in Africa. I speak Swahili, and I worked for the African Women's Coalition for a while as a community health worker there, working in a child abuse prevention program with parents and with young children, and doing all of those home visits. And then later, when the certification process happened in Oregon, joined the Capacitation Center and was able to train community health workers all across Oregon, and led the first 2 cohorts in the Black community that were the We Are Health cohorts that were really culturally specific. And it was the first time we were doing something that was really culturally specific to Black community health workers. And we added in a maternal and child health piece to it. That's not part of the state's requirement to have any part of the maternal and child health as community health worker training. It's like really seen more as part of the doula training, and many people are dually certified as community health workers and doulas. But we added the maternal and child health part and brought in Mama Shafia Monroe, people from HBI, a variety of different people to really talk about the legacy of the Black midwife, the problems of really systemic racism, medical apartheid, implicit bias, all of these things that we experience in the medical system, and how to be supportive of families. What was really sad is the first time we did that session, the day that we arrived, we were doing our training in a church, and the church, unbeknownst to me, the day before the training had found a Black baby in the trash can that had died, that someone had literally thrown away. And we had to stop the session for all of us to go to attend the funeral of this Black baby. So the maternal and child health session of Black Health, to attend the funeral of the death of a Black infant. And so I still get choked up talking about it. It just highlights some of the struggles that we have and how we had to organize around that. I think there's a lot of room for community health workers and doulas and midwives to all work together from different angles. I think that systemically, all three professions are undersupported by the system financially, and that creates challenges and barriers to doing that. But that doesn't mean that we can collectively organize ourselves.
Thank you for sharing that, Erica. I just wanted to just kind of give some understanding about some of the stuff that we're talking about, because I think all of us that are on this panel are having this discussion. I just want to let the general audience know that this is not easy work. And so, as you know, we're talking about very traumatic experiences. We listened to Kira Johnson's story when we talked in a little bit about the moment of silence for Dante, and you choked up a little bit. I've choked up a little bit. And it's like we have to continue to just move forward and have these conversations. So I just want to give acknowledgement because we are healers, and it's a spiritual experience that we have with the people that we're serving. Even if we're working on a community level, we have doctors on this, on this panel. And some of us are mothers, and so I just want to give acknowledgement to that if you get choked up, it's okay. But we have a tendency, particularly as Black women, to just choke it up and keep it moving. And I'm saying today, I know we're on a limited time, but we shouldn't always have to keep it moving. I'm talking it from a therapist lens, as a psychotherapist. Like, we need to take time for ourselves, and it means healing for the healers. And so I just want to acknowledge that, to just let everybody know that that's very important. We keep it moving, and we have to, have a lot of people on our shoulders, but it's okay. This is tough stuff. People are dying. Babies are dying. Families are suffering. And so this is why we have the village. So some days when Erica, you can't take it, I can hold it. I got you. I got you. I got you. And so I just wanted to acknowledge that. But thanks for sharing your experience in the Black Granny Midwives. And I definitely hope that we bring that. I know that we are bringing that practice back through community health workers and also community doulas. But now I want to kind of shift over to Deidre. You have been, you knew you wanted to be a nurse since you were 4. Like that,
Yes.
you wanted to take on that and you wanted to help people. I wanted to know a little bit more about like what made you decide to go into that profession. And then like, since you've been doing it for 43 years, you have a history and you have a story. And so I kind of just want you to share a little bit about what got you into the profession. What have you seen over the years as relates particularly to maternity care of Black women, in particular with Black birthing persons in general?
Well, thank you, Kimberly. Well, and thank everyone on this panel and attendees just for bringing light to this. I wanted to be a nurse. It was just in me. That's what I wanted to be. I had an older sister. We played, and she was the teacher, and I was going to be the nurse. And that seed was just planted in me, and it grew. So I've been in primary care the last 20 years of my profession. The thing that strikes me most is that I can't remember ever hearing anything about Black mortality and morbidity, Black maternity mortality and morbidity in any of the conferences I have attended in the last 15 years. I've been to conferences with primary care providers, 500 people, OHSU's internal medicine review conferences for 15 years in a row. And this was never a topic. And I polled one of my colleagues and I'm like, I'm on this panel, I'm learning about these statistics that are astonishing. And she agreed. We were in primary care. We were taking care of women who we take care up to a year after, birth. They come back to primary care less than a year actually after delivery sometimes. And we just were not aware. And I think a lot of us are still not aware. So I think, I'm just asking my colleagues in the women's health that maybe that's an area that we can reach out to primary care, do a lunch education. I actually want to send an email or plan to send emails to OHSU's continuing education committee to have this as part of one of the programs, and also to Samaritan Health to have this as part of continuing education. So it's just kind of astonishing to me that to be practicing, and I had to learn about this after I retired. So I think that's a big gap there. And so that's, I don't know, that's what has impacted me about everything that I'm learning today from you guys. And thank you for your work and dedication.
Okay. I just want to ask another question. I will, because my mom raised me right, I'm going to say Miss Green and not Deidre. So I was raised with Southern roots.
That's right.
I apologize for that. But I wanted to ask you, since you're just finding out about this after you've retired, like, do you feel like looking back in your career as a nurse that you were subjected to any type of institutional racism? Because a lot of times, we're faced with that as providers, as we're sitting with our coworkers who don't look like us. And so even though you're talking about, the statistics and disparities and equities now, do you feel like looking back in your career that you did experience some discrimination or you saw bias from doctors as they provided care to Black patients?
Let's see, I guess on a personal level, if I, experienced racism. I wasn't that aware of it. Like I'm more aware now. And I don't know, I just felt that I was prepared and I don't know, equal, adequate. So I didn't feel it on a personal basis. It could have been happening, but I really had a pretty good experience working at Samaritan. As far as implicit bias with patients, we don't have that large African American community in Corvallis and Albany. We have, Latin community, but it's still not that large compared to our white community. I think where the bias came in, it's almost more socioeconomic bias, like, or looking at the person's insurance plan. Like if you're on Oregon Health Plan, then you're kind of, I don't know, typecast sort of. So I think that it was more on a socioeconomic level than racial. And yes, for sure, different stereotypes about people, patients, little remarks or lower expectations. And so I can't exactly name specific incidents, but it was just that you looked at a chart, you saw, that they had this kind of insurance or that type of insurance, and you knew that some things will be covered, some not. And one thing I did notice too, that when Affordable Care Act came into being, that there was never enough credit given to Obama's the Affordable Care Act, how we were able to start reaching out to people after they went to the emergency room, after they got out of the hospitals. Before that was only after surgeries, people were reaching out to you. So that was starting the work, the community work. That's where the hospitals, I think, started getting a little more engaged in, knowing that the community was playing a big role in, the health economics of the country. So, but I say on a personal level, I don't think I experienced, or I just was too blind to see it. So, but yeah, that was my experience.
Okay. So now that, you're retired, but now you're working as a chair at NAACP in the health and wellness. Like, can you talk a little bit about, now that you have this epiphany or this awareness about what the issues are, what do you think your role primarily is going to be in terms of being the chair of the health and wellness project?
Yeah. So now I think my vision is like to serve the community, to serve and advocate for the Black community or people of color in our community. Just to let them know, to put a face on our committee, to let the public know that the NAACP, now we have a piece that will help people with health care. It's not all social issues, but also the healthcare. Healthcare is a social issue also, but that they can turn to us, and also being more. How can we be more proximal to our communities? We're all spread out, so it's a little different here. I can't go to the neighborhood, because we're kind of spread out. But just having events that focus and on bringing us together, like even wellness things, hiking, biking, walks, with NAACP participating in that, just getting to know people at the community level. And when we do have those kind of events, it brings people together and like, oh yeah, there's more of us here than we knew because we were all spread out. So, but it's really, I really feel honored to be part of NAACP. It's we're really doing good work, kind of joining together, we're showing up, and it's been a great experience. And I'm just so thankful that now I'm retired, I can concentrate on this and also have connections in the medical community that can help bridge that gap. So I see us as a link between the healthcare systems and the community, that, you know, we're going to be someone that either one of those pieces can reach out to, and we can be able to help. So.
Okay, thank you.
All right.
I like the way you talked a little bit about the community, and this is kind of, you know, what this discussion is about, is what is happening on the community level. And so I wanted to go one gear, but I'm going to switch over to Nadia and Dr. Martinez, because you all are physicians, or, you know, midwives. And so I just kind of want to get your perspective and your lens. I mean, either one of you all can go first, but I wanted to know, since we're really taking a look at this in terms of looking at institutional racism and Black maternal health, like in your particular roles, and I would just want to give a significant that, like you said, Ms. Green, that we are spread out in Oregon in general. We are spread out all over this state. And so for us to be able to come together like this is a powerful moment, for me especially. But I wanted to, you know, just the fact that Dr. Martinez and Dr. English and Williams, that you exist. The fact that you even exist is so powerful. And so I was wondering, I'll start off with you, Nadia, if you could talk a little bit about your educational journey, what made you to decide to become a naturopathic physician, what has been your experience like in Oregon, and just really what's the significance of you being a Black woman in your role as we talk about this topic?
Wow, that's definitely a loaded question there, quite a bit there to get to. So I'll start with the educational experience. So I went to a traditional 4-year undergraduate school straight out of high school, and you know, caveat being that back in high school even, I knew that I wanted to be in the field of obstetrics in some capacity. Back then, I had this vision of having this gigantic birth center. I'd be the lead obstetrician there, but we would practice in a scope similar to that of, you know, out of hospital midwives. So fast forward to, you know, my last years in undergrad, I then started to explore this scope of practice as a naturopathic physician that spoke to me in particular, because I knew that I have personal beliefs that our bodies are designed to function in and of itself, and that if I just supply the body with its, you know, basic living needs and resources, water, food, safety, and access to care, we could do our own thing. And so that's when I started wrapping my mind around the idea of naturopathic medicine. And then the midwifery portion came in a way concomitant to that. So I guess, yeah, definitely it is a unique experience being here in Oregon. So straight out of undergrad from Atlanta, Georgia, my then boyfriend, now husband, we relocated here, just the two of us, and I went straight into graduate school. It's a 4-year institution here. NCNM is what it was called. Now it's a university. And after completing that training, I then did a 1-year pretty intensive internship at a birth center here in Southwest Portland. And it is interesting. I do get the experience of often folks, friends, people in the community are often referring people to me, and I'm so very flattered, but I'm also like, there needs to be more of us, right? And so there is such a need, and I'm grateful to be here and be a part of meeting that need. But I would go on to say that what I'm doing currently at Oregon State University as a student in medical anthropology in particular is to extend that reach, right? And so when we're starting to think about the implications of institutional racism, I have my individual practice where I'm, you know, trying to provide one-on-one, culturally matched, centered, individualized care, but I also want to exceed my grasp just a bit more and think about policy formation and how to expand that sort of love to everyone, right? Yeah, does that start to answer your question a bit?
Yeah, I can get a little bit in the weeds, but yeah, I definitely wanted kind of an overview and then kind of hone in specifically. And I do want to say that I have referred lots of patients over to you because there aren't that many of you. And so I'm sure you are swamped and booked, but I'm going to keep on sending them over until you say no.
Thank you. I appreciate it.
Because it matters. And the fact that, as a doula, as a person that is not, kind of executive director of a nonprofit, they're asking, a lot of our clients are asking for a Black midwife or a Black OBGYN. And so, in the fact that it's a birth center, I mean, that's a whole different experience. We could spend a whole nother conversation about the difference in birthing in the hospital compared to birth center home births. But what do you feel like when you do get referrals for Black patients? What are some of the things that they're saying in terms of why they decided to seek out you besides me referring them over to you? I mean, other than that, like, what are they saying that makes them feel more comfortable and safe? And I think just kind of really talking about, you know, we haven't really talked about the safety aspect of why Black women don't feel safe or Black birthing people don't feel safe. But I think we need to really take a look at that in terms of measurements, in terms of outcomes, and not just about patient satisfaction, because that's kind of a generalization, but the safety component of why Black people don't feel safe in the hospital. Like, what are you doing differently to ensure that Black patients feel safe during their prenatal labor delivery part of care?
So that's a great question, because I think a lot of it, a common theme I've heard from people, especially those who have given birth before in a more conventional in-hospital setting, a lot of the themes I've heard is really wanting to know who's going to be that face when it's go time. And I think also forming those bonds and having one person to really streamline a lot of aspects of their care. And so oftentimes, because our practice is completely independent, we have a small enough setting to where my patients actually have access to my personal on-call line that rings to my cell phone. And that's from the time they start care with me until their baby's now 6 to 8 weeks, right? And so what that means is they know at a moment's notice if they have a pressing concern, they can reach me. And I think, unfortunately, some of the larger institutions, that's not as readily accessible. So a lot of people come wanting that need of having a very like personal, one-on-one, close, intimate relationship with a provider in that way. And so a lot of it, too, coming down to logistics, is my first time in-office visits are an hour long. A lot of what I can do with the person, meeting their biomedical needs, making sure that they are indeed, you know, bodies are competent and considered low risk, because that's my motto is low risk. I can do that pretty, 30 minutes. A lot of the time that I'm spending with people are also meeting other needs, often putting on a cap that is like a social worker perhaps, and connecting resources and asking people, how are they moving through the world? How's their job? And how is their access to food, water, safety, and integrating those themes. And I think that speaks a lot to what we're doing, at Oregon State in our Uplift lab, is really amplifying those social determinants and pulling that into the setting because it's already there. Just like we saw at the beginning of the presentation, it's 50% of it. Only that 20-30% is the true biomedical stuff. We got to bring in the other aspects. And I think that's a great thing that I'm able to do because my scope of practice allows for that much time and space.
Thank you. I like that holistic model of care approach, particularly as we're looking at reducing some of these disparities and inequities, looking at social determinants and like factors as nutrition and access to housing and jobs and all those different things that a lot of times are not taken into consideration, would definitely also contribute to a good birth outcome. So, Dr. Martinez, I kind of want to know, can you talk a little bit about your journey in becoming a physician and kind of what have you seen in your career, and just share about kind of what it's like in your experience with your patients and why you decided to go into this line of work.
Yeah, hi. Thank you guys so much for inviting me to join you. I apologize, I'm on duty right now, so a lot of stuff going on. But yeah, I knew I wanted to be an OBGYN when I was 8 years old. It used to be a great story. It's not so great now, but I saw a Black OBGYN doctor on television, and he was the very first Black doctor I ever saw in my life. And I was like, I could do that. And I set my mind to it, and here I am. So I left, I'm originally from Albuquerque, New Mexico, very similar to Oregon, not with the climate, but with the lack of African Americans in the population. There's a lot more Hispanics and Native Americans and of course, Caucasian Americans there. I attended a historically Black college in Louisiana called Xavier for medical school. I went to Tulane for, undergrad, and then I went to Tulane for medical school. I moved to New York and did my OBGYN residency. And then I returned home to New Mexico and practiced there for about 10 years. had a family and needed to take a break from the busyness of practice in that environment. And so that's how we ended up here about 2 years ago. And I'm still doing the same thing. I see a full scope of obstetrical patients, low risk, high risk, from the beginning all the way through the end of their pregnancy and postpartum. I also practice full scope gynecology, including, you know, annual visits and health screenings and birth control, as well as all the way up through major surgical procedures. And so it is a bit difficult here in Corvallis to try to be, you know, a force for change in the African American community, just because it is so small. But it's such a great feeling when I walk into a room and there's an African American patient that is just blown away and mind boggled that this Dr. Martinez that just walked in is in fact an African American doctor, and maybe they just never thought that that even existed here. And I've been able to, several opportunities since I've been here, you know, be that doctor for them and try to do that, just that more, that extra, going above and beyond, you know, what we're allowed to get to in, you know, 15 minutes in an office visit. I'm so grateful for the work that you guys do when you're able to spend a full hour with patients and get to the bottom of their psychosocial needs and be able to, you know, provide more of a community type of outreach to people. And that's absolutely what our community needs. And I think that, you know, the collaboration between birth workers and midwives and physicians is just the best possible way women can stay safe and have better outcomes.
Okay. What do you, this is kind of I also wanted to, and I'm also going to talk to the, you know, community folks as well about this, but since you two are physicians, I'll, you know, start with you, Dr. Martinez, because there's always this conversation that I have, you know, as a doula, as a childbirth educator, as a person that has worked with, you know, African American families, is like, what is it, this prescription people ask for, what is it that allows you, and Nadia in particular, to be able to engage with Black patients in a different kind of way? Because a lot of people want a PowerPoint presentation on how to do that. And I'm saying it's relational, it's organic, it's natural that we can do that. And so we couldn't tell you how to do it if we wanted to tell you how to do it, right? So, but I want to see if you can, in a way, like, speak to what that looks like. What does that engagement look like when you are specifically working with Black patients or Black women that are coming in for their maternal care? What is it that you do, or do you do anything different?
Yeah, I think that every situation, of course, can be different, but I really think if you just kind of strip off the layers first, right? You just be yourself and try to spend just a little bit of time getting to know somebody and letting them kind of get to know you a little bit without the barrier of title and position and profession, first and foremost. And I think just that little bit of extra time to be able to earn somebody's trust, it goes a very, very long way. And then I think that for me anyway, specifically, I try to provide my patients with education, you know, and the information behind why we do what we do and why we're recommending whatever it is that we're recommending for them for the health and safety and well-being of themselves and their child. I think that there's so much mistrust historically in, you know, minority communities and the healthcare system in general, just because of the history of this country. But I find in my practice that if I start by just trying to be kind and get to know someone a little bit, and then provide the education and evidence to why I'm recommending what I'm recommending, and we talk about it, and I let the people, or the person, excuse me, and their family kind of talk it through with me, you know, I think that's the way that works for me.
Okay. Dr. Williams, did you want to add anything to that in terms of your level of engagement and what you do and to be able to establish trust with patients?
I think I would echo what Dr. Martinez said, in that, you know, a lot of it comes down to building rapport and conversation, and then education too. I feel that a lot of times the resources that I'm able to see are, you know, as far as being a physician, there are often patient handouts and ways that you can convey information and have a true informed consent refusal conversation about just about anything. I do know that I have a pretty self-selecting population, and oftentimes they're researching me and knowing what I'm exactly about before even getting in the room. And so I think, again, just building that foundation of trust, mutual respect, and collaboration, right? Especially in the birthing journey and experience, because it is one that lasts, you know, a full year. So that's how I think, yeah, it comes down to the relationship. You got to just have it.
Okay, thank you for sharing that. Janie, I did not forget you. I wanted to give you the special time because as we, you know, shared the video with Kira Johnson, I wanted you to share your birth story and let everyone kind of know what your birth experience has been. We talked about, you know, just had an academic statistical overview of what it looks like in terms of Black maternal health. And then I'll come over to Senebu and Nakane around a community level. But I wanted to kind of give you this opportunity to talk about your story and what have you experienced as you birth your child.
Yeah, absolutely. Just to give a little background about me, I am a fifth generation born Oregonian. And so when I was 21 years old, I got pregnant. It was in my junior year. I was actually attending Oregon State University and didn't have a lot of support from my friends and family because I was in school at the time, and a lot of people thought that me having the baby, I would risk losing my scholarship. I had an academic scholarship that I was utilizing at the time, and so I was under a great amount of stress during the time, but overall, I was very healthy. The only issues that I had was mild asthma and reflux disease. So going into the pregnancy was a very, very healthy. I didn't have insurance at the time, and so I did go on the state Medicaid program, which, you know, Deidre had eloquently said, you know, that's some of the things that she saw. When I went to my doctor, I noticed that I had a certain color folder, and it said Medicaid on my folder, and that brought up alarm bells for me. And I had always been taught growing up that, you know, if you see something, say something. And so I actually did confront my doctor about it, and he was actually kind of embarrassed that I had seen the difference in my file, and reassured me that the clinic was going to take care of me, and that everything was going to be fine with my pregnancy, and that they wouldn't hold any tests or anything from me. And so as I went through my pregnancy, I started to build, because of that conversation that I did have with my doctor, I did start to build a little bit of trust with him. And but I did keep my eyes open. I really wanted to stay alert. And I went to every scheduled appointment that I was offered, and all of my appointments seemed pretty routine at the time. And so it was about when I hit about 27.5 weeks, I went in for a regularly scheduled appointment. It had only been 2 weeks since I'd seen my doctor, and I had noticed that I had gained some weight. I personally just assumed that it was normal because I hadn't gained any weight in my pregnancy to that point, and I knew that I was going to be starting my 3rd trimester. And so that's what happens when we will gain weight as the baby gains size. So it didn't really hit any alarm bells for me. But I went into the appointment, the nurse weighed me, and I noticed that I was 24 pounds up. And I thought, yeah, that is a lot of weight to kind of gain in a couple weeks. And so I went in, and then she took my blood pressure, and I could see the look on her face that something was wrong. But she didn't really say much and said that she was just going to go get the doctor. So the doctor came in, and asked me to kind of sit down or lay down onto the bed. And I thought, well, why, you know? And so I did as he said, and he took my blood pressure a couple times and then told me that it was really high and wanted to do an ultrasound. And I thought, okay, all right, whatever you say. So I went down and had an ultrasound done. The ultrasound tech, he really couldn't tell me anything definitively, but he did indicate the sex of my baby. I didn't know at that time, and he said I was having a girl, so I was excited about that. Went back up into the room, and the doctor had a really serious demeanor. He then told me that I was suffering from a condition called preeclampsia, and he explained the condition that I had was why I was experiencing the rapid weight gain. I was leaking protein in my urine, and my blood pressure was extremely high. He said that he was so concerned about my blood pressure that he was actually concerned that I was going to have a stroke. And so the seriousness of my pregnancy got really real. He also explained to me that during the ultrasound, they recognized that I had a partial placenta abruption, and it was showing that my baby had development delays, and there was worry that if the placenta had got more damaged, that my baby wouldn't get enough oxygen. So the plan now was that I needed to deliver my baby ASAP. And I just remember just being in awe, because at that point in time, I was a student and I still had 4 weeks left of the term. And I just figured I was going to finish school and then focus on baby as soon as my finals were over. And so to actually have to deal with the pregnancy right then and there was a little troublesome for me. And so he then explained to me that at 27 and a half weeks, Good Samaritan Hospital wasn't going to be able to take me. My baby was having a baby that soon. The hospital just didn't have the capacity to handle that type of birth. And so I was going to need to be ambulanced to Oregon Health Sciences University in Portland. And I was just in shock. I said, well, okay, let me just go home and grab, eat some lunch and pack a bag. And he was like, no, he says, ever since you approached me about the insurance thing, I've always been frank with you. He says, I'm not feeling comfortable about having you leave without having some type of health monitoring. And so, no, you need to stay here. And so I did, and the ambulance came and took me to Oregon Health Sciences University. When I got there, immediately they started giving me steroids and hormones so that the baby's lungs could develop, and then I was immediately put on Pitocin. It took a couple days. They just monitored me, and the baby seemed like she was doing okay. After a little while, the doctor came in and told me that that the baby was now showing signs of distress. It was a couple days after the fact that I had gotten there, and so they were going to prep me for a C-section. And so I was in the process of being prepped, and I was really nervous about this whole thing, because I kind of, even though I was going through having my labor induced, I kind of was under the impression that I was still going to have the baby naturally. So now I'm faced with now having a C-section. So what I did is I immediately called my aunt and uncle. They lived about 25 minutes from the hospital, and they are also both nurses. So I had them come to the hospital to be with me, and I was really glad that I did. And so they get there, and I'm on my side, and there was the doctor and the nurse. There was a nurse that was numbing my back to put in the epidural. And so as they were doing that, I immediately felt the sensation below, and I really felt this need to push, like my daughter was right there. And so I mentioned it to the doctor, and she just kind of said, you know, calm down, you know. I think she even called me sweetie, which didn't sit well with me. And so, and she kind of looked at my aunt to, you know, try to calm her down. And so I said, no, 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 no. I really feel something. Can you just take a minute to take a look and just see? And she's like, just please hold still. And at that point, I did something. I actually pushed her hand out of the way and rolled onto my back because I felt like I wasn't being heard. And I did what I was instincted to do, and I pushed, and out rolled my daughter onto the table. She was just there, not even attached to the placenta. And I mean, for a minute there, we all were in shock that she was just already here. And so the doctor sprang into action and grabbed my baby. I just got a kind of a glimpse at her, and then she was rushed off to the neonatal intensive care unit. And so as I laid there, they had to go in. I was bleeding. They had to go in and stop the bleeding, and then also remove the placenta that was still inside me. And so, and then I was taken to another part of the hospital because my blood pressure was still sky high. And my daughter was, of course, in the NICU unit. And so I was in the hospital wanting to see my daughter, and was told that I couldn't see her because of my blood pressure being so high. And if you know anything about Oregon Health Sciences University, it's a pretty big university. And so I was actually in one section of the hospital and would have to cross over the bridges to get to the neonatal unit. And so it was a ways, I was a ways from my daughter, but I still wanted to be able to meet her. I remember I'd had her that Thursday night, and days had passed, and I wasn't given the opportunity to see her. In fact, that Sunday happened to be Mother's Day. Here I was, a new mother, just delivered a baby and still hadn't met my child yet. And so it wasn't until Tuesday that I was able to finally get permission from my doctors to finally go and meet my precious daughter. When she was born, she weighed 2 pounds, 6 ounces, and ended up being in the unit for a couple of months. And so the story didn't just end there. My blood pressure never ever went down, even though they had told me with preeclampsia, that's what happens. Your blood pressure will go down after delivery. And when it first didn't go down, they said, well, sometimes it takes your body a while to adjust back to normal. 3 months passed, still had high blood pressure. 6 months passed, still had high blood pressure. At that point, I went back to OHSU and I said to them, I need to know what's wrong with me. There's something else going on here. And so they did a whole bunch of tests on me, and it was determined that I had a condition called glomerulonephritis. And it's my kidneys were damaged as a result of the preeclampsia. And that is just something that I had no idea would ever happen. I didn't know that preeclampsia affected Black women as much as it does. And so they said, well, you know, your kidneys are damaged. You know, you probably won't, you'll just have to have just, you know, the lessen or the reduced function in your kidney. We don't expect that you would go into complete kidney failure. Well, 6 months later, I did in fact go into complete kidney failure. So now I'm here, I'm 23 years old with a small child, and now needing to go on to dialysis. And so, yeah, that's been my struggle now. you know, 20 some years now later, I'm 2 transplants in, looking to go to have need another transplant soon. So yeah, that's what happened with me and my birth.
Well, thank you for sharing that, Janie. There's a lot of things that came up as you're sharing your story.
So much.
Yeah, so much things that I'm sure I can look at everybody else's faces. There's so many things that just hearing your story, but definitely understanding that preeclampsia is a common condition with, you know, African American women. But I also feel like the way you're telling your story is that you walked in educated and knowledgeable with the doctor that you trusted. And I think that's something that we, you know, really need to talk about as we're talking about changes in the medical system and how to better support Black birthing people in general, is like feeling confident, like feeling educated, feeling, I mean, Erica talked a little bit about that as well in terms of, and Deidre did too, Ms. Green, around having women go in and feel confident and feel educated and feel, you know, knowledgeable. And even if they don't know, they know who to go to. And so having a good primary care physician adds to that. So it sounds like it wasn't the ideal situation and birth experience that you dreamed of, but you were able to navigate through the process in a very healthy way from the way you're telling the story. So I'm glad that you're able to share that and the importance of walking in, having some information and knowledge. Because that was going to be my question for you, because I didn't know your story. I was going to ask you, and I think as providers, we forget, as community health workers, as doulas, as medical professionals, we forget that with these statistics, I mean, as a Black, you know, Black birthing person that's having a baby, it's got to be scary to hear you know, all these inequities and disparities and the deaths and 3 to 5 times higher. And like, I don't think people really realize what that does to a person when they're trying to have their baby. When they, I mean, it's good to know the statistic and it's good to know all the things that could compromise your pregnancy or your birth, but it's also scary to know that you are you could be that statistic. And so I think to be very, to demonstrate humility and as we work with patients and things like that. But I think from what I heard from you, I mean, you definitely walk through it with a lot of dignity.
Yes.
Thank you for sharing that. Thank you.
Thank you.
I want to kind of shift now to the more of the community level, because this is what we're talking about. We say healthy communities begin with healthy pregnancies. And so as you all know, I think it was, I'm not correct on the date, I want to say it was Tuesday when Biden and Kamala Harris, the administration, declared a proclamation that April 11th or April 17th is a Black maternal health, and that this is a public health issue, and that we need to be aware of what's been going on, that some of us have known has been going on for quite some time. And then also with the Black Maternal Caucus, I don't know if you all are familiar with the Black Maternal Caucus. I had an opportunity to meet with Congressman Laura Underwood from Illinois, and then there's Congressman Alma Adams from, I think she's from North Carolina, that really started the Black Maternal Caucus in 2019 to really take a look at legislation, policies, how to better support community-based organizations, how to support culturally matched care. And so we are seeing a shift in this country in terms of taking this issue seriously, and that it is a public health issue, and that we need to address it from different elements. So I wanted to like kind of give this time to Mikane and Zainab, because you all are out in the community, you know, at the community level. And I wanted to just talk about what are you, it relates to that context of really looking at it from a national lens. And so on the ground, what are you all seeing in terms of your role and your efforts? I guess I'll start with Sunbu, because you are equity coordinator, and so in Benton County. And so I wanted to know specifically, because we really haven't talked about cultural matched care and what that means, because I think people use the word culturally appropriate and culturally matched. Those are 2 different things. And so we need to understand, I'm a big advocate about culturally specific care and what that looks like. Historical, really what Erica's saying, having a historical framework and a cultural framework of how to be able to work with patients and understanding their history within that context. But what about you, Zainab? Tell me what your vision is in terms of your role as an equity coordinator and you're part of the neck of the woods, I guess. What is your strategies and what are you looking at and what are you seeing?
I think I'm glad that you're bringing it back. I like the distinction that you made on cultural specific care, because it can be appropriate, but it may not be specific to the experience of that patient that you have right here. So as far as the work that I would want to do through the Linn Benton Health Equity Alliance, I'll start off by saying that I have always brought my entire self, my identity, and all of my intersections with me into every position and project I've ever participated in. And I don't think that my position as the coordinator of the Linn Benton Health Equity Alliance will be any different. As far as what my plans are for this is to have let me dial it back. I guess where I'm coming from, I was really inspired when in college, I attended Spelman College. I love the HBCU unity that we have here. And in there, I learned about the Combahee River Collective, which is an organization of Black lesbian socialists from the 70s and 80s that talked about the importance of the political is personal and the personal is political. And I believe that our politics have to match and elevate the quality of life that we want for ourselves and ultimately each other. So my approach is to have of course, a health equity, but also a community health and development framework that leads the work in Linn Benton Health Equity Alliance, and ultimately recognizing that racial inequity is at the core of many systems of oppression that burdens all of our lives. You know, we're talking about Black women, Black folks, but racism burdens a lot of communities of color that in different ways, but ultimately for the same reason, which is just, to marginalize folks. So with that, I've taken April to commemorate Minority Health Month, which kind of birthed this panel today, to talk about the highlight different communities that have been minoritized through racism and other systems of oppression. And I think that it's important that we learn from each other's experiences. I've learned so much just by learning from Janie's experiences, learning from Deidre and Dr. English Williams as well, and learning how to incorporate their experiences to prevent further harm. This even informed my time before my position here at the Linn Benton Health Equity Alliance. I worked as a reproductive health counselor, health provider at a Black-led abortion and gynecological clinic here in Atlanta, Georgia. And it's then that I understood the importance of, like you said, Kimberly, culturally specific care, because my organization was Black-led and we service a lot of Black and Latinx communities there. And I learned firsthand the importance of a person-centered approach, but even more so than that, but just the effect of having a provider that looks like you and also probably has experiences similar to you is very crucial to patients, because I think that a lot of times, to your point about having patients to have agency, to feel confident, to call out things like Janie did about, the folder and then certain things that you're experiencing, a lot of times that agency isn't always afforded to us. But if we're coming to somebody who, for the most part, have a similar understanding and experience to us, we're not engaged in a conversation where we have to explain who we are or explain why. We're engaging in a conversation and just telling you, this is what I identified, this is what I'm concerned about, what can we do to prevent that, reduce that, or abolish that, And too often times Black patients suffer at the hands of health and medical care without the opportunity to effectively advocate for themselves in a way that is not only explaining who they are, but also inviting providers to help them to heal. I really appreciate that you brought up that point about Kamala Harris, because I think she put it so poignantly in saying that it cannot be for Black women alone to fight for their rights and fight for their dignity. We're having to fight for living just to live, just to have a family, and then on top of that have to fight for our rights and dignity is something that will ultimately slow down the process of healing for all of us. It's ultimately the responsibility of the nation and the communities within the nation to uplift our voices, to uplift our experiences of Black birthing persons to prevent this from happening. So on a community level, it's, storytelling is so important, especially in the Black African American community. What we're doing, this is storytelling. This panel is storytelling, and how we're able to listen to Erica's experiences from Kenya, how we can listen to Deidre's experiences from San Francisco and everything. We're ultimately creating a place here to where we can have kind of like a pot of gold of experiences that can help inform our decisions, whether we're providers or even on the ground, you know. I think that community, as Black folks, are very communal people. The way that we engage, the way that we listen. I muted myself, but every time somebody said something, we always engage. Like that non-verbal communication, that's community. That's storytelling. That's engaging with somebody on a very intimate, interpersonal level, where when we walk away, I can still think about Janie's story and still be empowered by the ways that she has enacted and stood in her agency. Just like how other community health workers, that's the community is ultimately just supporting the agency of an individual, you know. And I think through the Linn Benton Health Equity Alliance, that's ultimately the power and the force that I'm engaging with. I'm not the community. I'm merely a liaison. I am a mirror. I am a connector or resource for the community. However, I think our most powerful tool is storytelling and reaching out and speaking out our truths to engage with folks, to put a face to experiences and invite people to that. So this is poignant. This is powerful. You know, having all of these people here, it's really powerful.
Well, I'm going to do my call or response and say, yeah, absolutely.
Okay.
I feel you on that. And so I like the way that you got to really give an overview of what it looks like in terms of the Black-led piece, the culture specificity, and how we are, cultural people, and we're very relational. And this, us having come together as this kind of village forum, and also helping people that don't look like us really have a better understanding, a historical and a contextual understanding of how we show up. And it's very important to be able to understand that. And it's also important for it to come from us. And I want to emphasize the importance of trusting Black women, trusting Black voices, trusting our story, that we can represent, and we are equipped to work with our community. And so there aren't a lot here in Oregon, but I'm happy for those of you that are here, because I feel very inspired and confident as a person that leads a Black-led nonprofit to use doulas as an intervention. It's a little different when it's Black-led. It's going to be a little, we're going to have some pitch. Erica talked about it, about having images that look like our community, having certain foods that when you walk into the building, you can smell certain scents and things like that. Like, that's culture. That is not just about being at a prenatal visit. It's all the things that lead up to that, the car ride for the community health workers or doulas and things like that. So, but then also for us to be able to come together and be able to have an intellectually engaging conversation about what we need to do. And so I'm really inspired by Biden and Harris in terms of administration, really looking at what we can do. Senator, I have so many yay girl for you. I can't even, I wanted to stop you every second you're talking. It's just so refreshing to hear that, to be able to be your authentic self. And I want to say that for those of us that are doing culture specific work and culturally matched work, or we're leading Black-led organizations, we have to bring our full self to the work. This is not something that we do a 9 to 5 and then we cut it off at 5:05. Like, this is spiritual. This birth work and this being in Black maternal health is spiritual, is transformative, and you can't just turn it off. I mean, I know we need to do some self-care, so I hope people are taking care of themselves and getting a massage or drinking some tea or something like that. I just want to give for the audience to understand that this is who we are. This is our community. This is our people. This is how we are raised. And so it's more than just a job for us. Like, we have, Kira could have been our cousin. Kira could have been my daughter. Kira could have been somebody's mom. You know, Dante, I mean, could be my son. You know, so this is a little different for us. And that's what I'm saying, Erica spoke eloquently to that, the historical and contextual understanding of trauma. Like, this is a focus work as well. And so being able to really understand how to work with our community, when we talk about healthy communities, starting with healthy pregnancies, it's also understanding within the context and how people show up as Black people. I can go on and on, but we got to look at the time. So Mekane, I wanted to talk a little bit about your work. I know you are a community doula, you're a curriculum developer, you're a community organizer. Can you talk a little bit about your work and what your vision is in terms of like what your experience has been in your work?
Thank you. So I think for me, the way that I came into this work was like by accident. I ran as far away from all this as I could. And it's almost like what is that saying? Wherever you go, there you are. So I came to Oregon mid-30s to pursue a master's degree after being out of school for years, and knew that I wanted to work in Ethiopia, where my parents are from, and just really struggled with a sense of belonging where my work was situated. I got a degree in anthropology when I was younger, had a very difficult experience navigating the college system. I worked full time, took me 6.5 years to get my first degree, went to 4 different schools, including community colleges. I had to figure out everything on my own from the time that, basically I started to go to school. My parents are refugees, came from Ethiopia in 1982. I grew up in a very white rural area in Virginia. And that piece of how much we kind of have to go through, like we got to do all the things just to get to what we want to do. And so I worked, airline job, customer service, all the different things, worked as a restaurant employee, was always just trying to figure it out. And I didn't really use my degree at all after I got it. And lived in Philadelphia for 5 years, where I lived with I worked with almost all Black women from the diaspora in Philly, lived in West Philly. And what's funny is my sister was actually trained as a doula, and she's working for Maternity Care Coalition in Philadelphia, which is, the burnout rate is ridiculous. And I watched her go through all this. I watched her go through pre-med. I watched her at every single turn really have to fight for her place. And my mom's a nurse, and I had just seen this sort of Black women literally putting their health on the line to fill these gaps. And I think especially coming from a class of women that I just seen so exploited my whole life, I was just like, I kept trying to do all these other things to try to figure out other ways to sort of help without necessarily being on the front lines. And when I came to Oregon State, Dr. Cheney invited me to have a desk space in the reproductive lab, is what it was called at the time. I wasn't one of her students. She wasn't on my committee, but she was like, you don't belong down there. Like, come up here, I'll give you a little space. And I looked around, and there's all these pictures of women giving birth, just full on, no clothes on, baby coming out, crowning. And I think you would have thought I would have been like, ugh, but I was like, all right, I like this space. And so I just ended up being sort of in this spaces. I went to go do my research in northern Ethiopia, and I just found that what I was experiencing there and what I'd experienced my whole life were incredibly brilliant, resilient, community-oriented women who just always figured it out. My grandmother had 8 kids. All my grandmothers, they had their kids at home. 8 kids, no running water, right? Y'all figured all this out, raised your kids up, went through so many miscarriages. There's a high infant, Ethiopia's red on that map that you showed earlier. And yet I'm like, but y'all are the smartest women I know. And how can these statistics and then the way that they frame this information, there's just this disconnect. So then I was like, okay, what's structural? You start kind of paying attention to these things, and all these sort of experiences that you have in your life, they start to sort of come into focus. Well, after I graduated, I had the opportunity to do the doula training and start to work actually more closely with the reproductive lab. And I did the doula training, and it was everything just made sense. I didn't even realize just how much I was terrified, in my body. I disconnected from my body with all this information that I've been around, all this sort of racism that I've been experiencing. I didn't even realize just how much it had made me truly afraid. All my friends' birth stories of having a child, something wasn't right. When I did the doula training, I'm like, yes, the intuition, that feeling, that knowledge that there's something wrong about the way we're being forced to do this. And I think the piece around having all the information and knowledge, I would have hoped that would have helped. But in some ways, I found that even more traumatizing, because when you go in and you feel like you have that knowledge and you're empowered, and then you feel like, okay, I've got this, I have the best health insurance. I have money. I've hired all these different people. One of my closest friends, her husband's a doctor, you know, like she had a horrifying experience with her first child. And so that started to really click for me. And as I've gone on my own journey, I've realized that it's not for lack of even like understanding or for care or for love. It's truly structural. And the other piece is that we live in the system where women have, like, you get I was the airline, we had a union, but you still got 2 weeks off, 2 weeks paid. Like, how does that even make sense, right? Like, we know that it takes time to heal. And so I think I'm back. Lost up for a second. Yeah, and so it's just these really basic things. Like, I'm realizing the other piece is we talk about equity, but equity means that we need more. Not like people are still on this equality piece. I'm like, no. I need more time. And as a Black woman, like, I feel like if it had been 5, 10, 15 years ago, I would have been able to ask for that, because I would have been like, I need to be strong. I need to show that, like, I can do this. No, like, I need 3 years off, and I need that to be paid. And I don't care what other people are doing or what other people are getting. I know what we need, our community needs, and that's what I'm going to ask for. I'm not going to base it on, well, you know, we get this, that means we have to do. No, because I'm so glad that you brought up the Combahee River Collective. You know, if Black queer women were free, it would facilitate the freedom of everyone, right? We all rise up. If you center the most vulnerable, everyone benefits. And so if we take it all the way back and we say we need rest, we need access to resources, we need money. Like, that's such a basic thing. Just put money in people's hands. It shouldn't matter what criteria they're hitting. Just give them the money and let them do what they need to do with it. If you're having a baby, you should get a certain amount of money every month, so you don't have to worry about that. It's like these material things cause all this stress. We're not going to fix systemic racism all at once. We're not going to fix people's microaggressions. We're not, you know, but there are things that we can do that are so straightforward and that offer wraparound services to people. And we're constantly having to fight for what we know we should have. We're constantly having to explain over and over again why we deserve to have these, like, basic human rights. And I think what I've come to in my work is, like, I'm almost to the point where we just need to do it, and we need to take the people with us that want to do it. And if people aren't on code, like, they're gonna have to get there at some point. But this is now. And so I just feel that coming from this background, of kind of coming to this later, it was just this big sort of like eye-opening piece. But, like, I'll tell you right now, I'm on Medicaid as we speak. I was unemployed after I finished grad school, and the prospect of having a child, even now for me, is still very terrifying, even though I'm doing this work, because it is so much uncertainty. And so I think that we need to be really honest about that, is that we still live in a system that is extremely broken for everyone. And then, of course, it's going to disproportionately affect all of us who are already dealing with everything else. So, yeah, thank you.
Thank you for sharing that. You made a lot of really good points, but and I kind of just lost my train of thought in terms of kind of where I wanted to go with that. But just like the having the lived experience, you know, really, and I know what it was around equity. There's folks that are still stuck on equality, meaning everybody gets the same thing, and we're saying we want a racial equity, and I'm saying racial equity and economic focus. Because we need a workforce. We need to have a workforce of folks that look like the folks that we're serving that are most in need, that are most vulnerable. And so I think that's this whole awareness about what does equity look like, and there are going to be certain advantages or certain provisions that have been given to people that haven't been given to them before. And so that's fair too. That's not equality, but that is equity. And kind of what does that look like for folks, and how does that play out? So I guess I don't know where we're at with that. I know we're over the time, and I already knew I was going to be over the time, so somebody should have. All of us are over the time, and I don't know which we want to open up for question and answers and how we should proceed forward. But I just wanted to, like, as you all know about everything we've talked about, having this discussion, really having a strategic plan, because I think that we all are on the front lines and we are working with our communities directly. And we do have a privilege and we do have positions of power. So I believe that too much is given, much is required. And so we do have a lot of work that we need to do. So I guess my question is, now that there is this national awareness that this is, if you talk about infant and maternal mortality and morbidity rate, and we have the highest position in the land, I guess, with Joe Biden and Kamala Harris saying that this is an issue that needs to be addressed. They're putting funding in. Like, what are, just in one sentence, I just want to go across and just ask everyone, what do you feel like you can do in your day-to-day work to work towards improving these outcomes, particularly as relates to Black birthing people? I'll start with you, Ms. Green. What would you say that you can do tomorrow to start this process?
Collaborate and get proximate with the community and hear them, hear the voices of the community. What do they need? Yeah.
Erica?
I believe you're muted, Erica.
Erica. I know it's hard to put it in one sentence. I know it is, but I
think I agree. It's about letting the community lead. I also really loved what McNay said, and I think it's also making space for us to be able to rest and heal, because these structural things that we're talking about, it's not just that we're fighting them right now, it's that we've always been fighting them. And so that's just exhausting on a physical, mental, emotional level. So I think it's about making space to heal ourselves and each other.
Mm-hmm.
Erica, that would be my strategy as an equity differential payment. Like, we should be getting differential pay, because that's an equity strategy, because we are dealing with something, especially because we experience it ourselves. McNay, what is your takeaway or one sentence to what you can do specifically to address this issue that we've been talking about today?
Healing and transformation, and just for me, I'm about unapologetically creating and holding space, a container for people to be fully ourselves, indigenous practices, spiritual, not having to hold back any of it, to bring all of it fully, and to not be afraid or feel bad for doing
that. Dr. Williams?
I would say what I could do is tell stories, really amplify the voices and the stories to whatever audience or whomever I can touch, sharing those.
Okay. Janie?
Yeah, it's the same for me. I continue to speak my story and just to let women know to listen to their body and speak out.
Sustainable?
Also powerful. I would say empowering communities by empowering individuals, just reminding them that we truly have all of the answers and questions that we have within ourselves. We're never in lack, we're always full. So operating with that, not a deficit mindset or scarcity mindset, but like, I am full and y'all just gonna have to make space for me. It's not a matter of me shrinking, it's a matter of y'all expanding. Thank you, I know y'all feel me.
Well, thank you all very much, panelists. Thanks for this rich discussion. I'm sure that the audience has learned a lot from you all, and you all definitely inspire me as you continue to do your work. I guess I want to open it up to the audience for questions and answers. Do we have anyone that would like to ask a question to any of the panelists?
as you know, I'm pretty sure people are having to get their questions together. So as they're getting it together, I just wanted to give a shout out to you, Kimberly, because you have facilitated a bomb.com conversation. Okay, the questions were on point, the conversation was rolling, but ultimately it felt like storytelling. And I know it's not new to you, it's true to you. So I just wanted to give you your accolades. I want to give you your props and really thank you for engaging with us, our truths, our stories, and knowing how to listen to it and shine it out. And that's what meant to me the most. So thank you so much for engaging with us.
Thank you. Thank you.
And Kimberly, while we're waiting for questions, this is Dr. Martinez. I was able to pop back on here, but just with audio. And I just wanted to add my piece that, you know, as a physician that really is on that last line of defense to prevent death, you know, my role is to teach the next generation coming up after me to listen to Black women and make sure that when I'm around on labor and delivery, any Black patients that we have, any minority patients and people of color, that all of the people that are working with me and around me understand that that has to be a priority. Yeah.
Yes, thank you for saying that, Dr. Martinez. Thank you for coming.
Thank you for having me.
Is anyone, you see any questions coming in? I don't see any questions.
You may just blow them away. You just blew them away.
Well, I knew it was going to be thought-provoking, so definitely, I'm sure I know a lot of the questions that people had and I've talked to in the community in terms of how to better support Black women in particular. There has been a lot of dialogue as a person that works in the birthing community around how to better support. And I would highly recommend supporting Black-led organizations, supporting sponsoring, scholarshiping people, you know, to go into certain professions, to become a doctor like Nadia, become a doula, to become a community health worker. Like we need to create a workforce that represents the people that we're serving. And so in all positions, I know, like I don't know if I shared, I came from Detroit, Michigan, which is all you all know is a very Black city, probably 85% African American. So it was definitely culture shock coming here. So I kind of, like Rickene said, I kind of came into this work from a social work, clinical social work therapist, and it kind of just landed in my lap as I started to hearing these, you know, horrible birth stories. And so as I came and I looked around and I started, where are my people? I don't see anybody that looks like me. And so then I was like, okay, so then I learned very early on when I came, I've been here for 12 years. I learned early on that I have to create what I want to see. And so, you know, for me, that's what it has been. And I just happen to take the doula profession as a way to be able to support women in the hospital. And I've had African women say you make sure you never have a Black woman in the hospital by herself. And so I doula to be there to go to prenatal, labor, delivery, and also postpartum care. But I wanted to say that somebody made this comment about being a super Black woman. And I wanted to say, as a doula, as a community doula specifically, a full circle doula, a birth and postpartum doula, and that's one of our biggest struggles. And we really know that that's going to play a part in maternal morbidity and mortality, is that Black women don't feel like they need support, the postpartum doula. And they do need support during that critical period, making sure that their babies are seeing a pediatrician or making sure their health is in order. So, but that's a context of having this super Black woman, I got this. And it's like, no, sis, you don't got this. And that's why we have a postpartum doula to come in and help you prepare meals, to help you when you have other babies, or to help you when you're living, you know, in Southeast Portland and you are on OHP and you're on Medicaid and you live on the 3rd floor, but you have, you're bringing up 2 little babies up there after you just had a C-section. Like we really did, you know, Jane talked about that a little bit, and a lot of these moms are single moms and things like that. So really understanding, you know, our community, you know, in terms of economically what they're faced with as they're trying to navigate through their childbearing years. So that's also an important point as well. I know we didn't spend a lot of time talking about doulas, but that's kind of my lane. And I think that they're very important and they're very valuable. And I also heard the other night, Kamala Harris talked about the importance of doulas. So I'm really, there's more TV shows that you're starting to see doulas incorporated into medical care. So I'm really excited about where we're moving. in this country in terms of really taking Black lives seriously.
Absolutely.
I don't think, are there any questions?
Yes, there's about 4 questions. If you would like, I can read them out to you. It's in the chat.
Yeah.
So the first question I see here is, what can an individual do to improve equity for all, either as a healthcare provider or just a normal everyday person?
Anybody want to answer that? What are your perspectives on that?
Educate yourself. Educate yourself and not have knee-jerk reactions to the answers or to what you hear. But I think it's, you know, it's up to people to educate themselves about what's going on. And, you know, we don't have the energy for that too, or what we've been dealing with, and then the energy to educate everyone else. So I think do that. That's what I would say. Educate yourself about the issues that are that we've discussed.
I think I would add on top of education that often when we're facing like in conversation or just like that experience, it's okay to say, I don't know, to an answer to something. It's much safer and better to say, I don't know, than to possibly fabricate something that may not be true. But the harm is really in saying, and responding with, I don't care. That's usually where that's where the line can be drawn. And I would just say, be realistic about your lane, like we say, and lane could be in your identity, in your experience, and knowing that equity, that this fight for equity will not, like how we say, we won't solve the problems of racism by ourselves. And so learning how to tap into communities who are also doing that work too, just so it doesn't, you know, contribute to your own burnout, and learning that you're not the only person wanting to do that, and that this is a very real attainable goal for equity is very real, because there's other people also doing that work as well. We're more powerful in numbers and community. So I would add, that's what I would add on to Ms. Green's point.
I would also, and this is kind of another question that was posed at the bottom, but I would also, like you said, Zainabu, is staying in your lane. If you feel like you're not the best person, the best provider to serve this particular patient, refer them to somebody that can, and don't feel like you have to serve everyone. And I think that's the equity plan, equity kind of a lens as well, is refer them over to a Black provider, refer them over to a Black doula. Like, be okay with that and understand that, you know, right now, and I mean, not just since George Floyd was murdered, and Dante, and there's a litany list of people that have been murdered, but it seems like this country has become more aware in 2020 that there's a lack of trust. There's historically been a lack of trust from Black people by the medical system. So it might be just better for you to try to stop that tension that's organically there, that you didn't do anything because of the color of your skin. It might be better to refer them to somebody else that looks like them, just so they'll feel safe.
Yeah. That's probably, we actually have someone in the audience who is looking for a Black physician who can provide holistic care. And I know Dr. English Williams is exactly, that sounds like we can definitely direct to Dr. English Williams, Dr. Martinez, who was also here as well. Perhaps Dr. English Williams, did you want to, the question itself reads, what do you all recommend for families seeking culturally matched care in the community?
So I would say, you know, I can probably answer 2 questions in one. And so from a health provider standpoint, will be to probably compile a list of resources. And so know about HBI, BPI, all the acronyms, nonprofits, and support that. But for patients, there are a lot of resources on, I know there are Facebook groups and Twitter that will mention who are the best, you know, providers for this kind of service, pediatric, dermatology, you name it. So utilizing those social platforms, especially.
That's powering. Thank you so much. Don't want to skip over any other question. Let's see. What can we do to support your work in our community? Social media is a beautiful platform, so repost, like, engage with our content. The Benton Health Equity Alliance does have a Facebook. where a lot of this information was posted there. So I would definitely say that. And learning more about the work that is being done in our respective practices and organizations, and having just a general awareness of what kind of folks in the community would be interested in that kind of work, and having those resources readily available to share. I don't know if anybody else had anything to add on what could be done to support your work in our community.
Well, I know I'm the moderator, but I'm also the executive director of the Community Doula Alliance. So I'm going to give a plug to the Community Doula Alliance. And we are a Black-led, I'm the Black lady leading it, of the nonprofit. And so to be able to have doulas, particularly Black, Indigenous, and Native American doulas, or Indigenous doulas. And so, you know, you can support us by looking at our website. We have a website we just started, so we're a new nonprofit. September of 2020, we became a nonprofit, but we became a nonprofit to address this public health issue as it relates to infant and maternal mortality rate in the Black community, but also understanding the disparities as well with Native Americans and Indigenous folks. So you can support us by donating. We have a fundraiser page. You can donate funds to be able to have more Black doulas. You can also support their education. And then we also have, we're going to be culturally matching, have a culture specific match between our families and doulas. So you definitely can support us. We're on Instagram, we're on Facebook.
Powerful. Thank you so much for plugging your amazing organization in. Let's see, just reviewing other questions. Another question reads, as a Caucasian birth worker, how can I best support Black maternal health and help foster equity? Are there any particular local resources that you recommend that I can connect clients with? Besides Kimberly's amazing organization, I'm interested, you know, what other people would give advice to a Caucasian birth worker. I know we spoke about referring patients to, you know, just kind of avoiding that tension and just referring them to a provider that looks like them. But in the case where that's not, you know, an option, what do you think we can offer and share advice to Caucasian birth workers?
This answers that question partially, and maybe some of the other questions as well. I think it's important to ask ourselves why there aren't more Black people in Oregon, and why we can't really retain Black women in Oregon. I know that's coming from the academic side, and I think, you know, there's a wanting for folks to come and do this work, but there's not a readiness. And I think that, you know, just as a garden needs to be prepared and the soil needs to be prepared, we got to think about what that could look like. And so I think for a lot of folk, if they're really doing the anti-racist decolonizing work internally on themselves, which isn't easy and often means having to let go of a lot of comfort, then you pretty much, as you do that healing work, to really think about what your ancestral trauma looks like as folk that maybe from the dominant culture, then you kind of start to have a general understanding and an openness of what needs to happen. Like, you don't really need to be told as much as you start to do that work on yourself. And so I think that it's also about what needs to happen in the communities so that Black birth workers want to be part of those communities, and don't then showing up and having everyone referred to them and burning out or having to sort of hold the container. I know in the academy, what's really hard as a Black woman is we show up, we immediately become mammy, and everybody wants to throw everything at us, and our livelihood then becomes all about our identity and not so much about us as a whole person, as a community member. And so I think that we also need to think about what are the things that folks can do on their own without having their hand held necessarily, to start to create a space that makes us want to stay, to be quite honest, and do this work. And so as far as the resources go, I'll default to someone else about that. Obviously the Community Doula Program and Uplift Lab are great resources, but I think there's folks here that can speak more to that.
Well, Dr. Williams spoke to that. We have the Black Parent Initiative. They definitely have Sacred Roots Doula Program. You know, the Healthy Birth Initiative. They have Nurse Family Partnerships. I think those are the main two as it relates to early childhood and when it comes to doula care. Those are it's culture specific in terms of Black in particular. But I totally agree with you, Mekane, is to do your own research and don't feel like you have to like suck the life out of a Black person when you see them about how to help you navigate racism. Like there's a lot of books out there. There's a lot of that are written by Black people that you can resource, look at for yourself. But just being knowledgeable of that and not feeling like you're putting pressure on that person and they feel like they have to educate you about things that have happened to them. And then also understanding that I will say this as well, is that sometimes, seeing these Dante Wright stories and Trayvon Martin and all these other George Floyd, it's traumatizing for those of us to see that every day. And I notice that a lot of times, my white colleagues want to post things, but it's traumatizing to see that all the time, because that could be one of our own family members. So be mindful and cautious of that, because I've seen a lot of that going on when people want to say, oh, I'm an ally with you, and then you show me this video of somebody getting killed. Like, that's not a way to ally with Kimberly Porter. I'm just gonna tell you that right off the bat. Like that, don't do that. Don't do that. And so, just trying to be supportive in an educational way. Everything I do out of the kindness of my heart is not a means to shame anybody, but it's just to be more thoughtful about some of the things that you're doing to try to engage with Black people. It's just to be more understanding of what you're doing. So I just want to kind of put that out there as well.
That's powerful. Only thing I would add on top of that is call out your white colleagues. Don't wait for us to call them out. It's tiring and taxing. And if you see your, other birth coworkers who are doing things that you might feel is questionable, call them out. Because if you feel it's questionable, it probably is. Call them out. Don't wait. Don't ask if you shoulda, coulda, woulda. No, call them out in that moment. And that's when you start garnering a little bit more confidence in calling your own colleagues out who may be perpetuating the inequities that you're actively working against. So I would say that on top of that. I'm not sure if anybody else had anything other to say. There was one more question and another comment that would like to be shared, but
I think that's it. That's the last question, I think.
Oh, it is? Okay. There was this one question here. How can we best encourage Black women to embrace and exercise their own bodily autonomy and birthing power in the face of our industrial birth system in light of such high rates of risk conditions among Black mothers? Whew.
Whoa. Who wants to tackle?
Man.
Tell me when you find the answer.
I have an idea. I think when I meet some people, I'm always flabbergasted by how many people will say to me, as a person who is supposed to look at a person's health history and then determine if they are indeed low risk or high risk. People who come to me and say, oh yeah, I'm high risk, or this always happens to me and my family, and really convincing them to take a step back from that narrative and not think of their Black skin as a curse, and think about all the ways in which those stories and how that trauma may have been embodied can look differently in their body. So I think when we talk about agency and autonomy, is fully acknowledging your family's health histories and stories, but thinking about you and having, or even just daring to think radically and imaginatively about what kind of birth experience you want to have, and daring to want to pull that into your life. So I think it comes down to conversation and showing people that things can look differently for you, and maybe that's videos, maybe that's pulling up blogs, whatever have you, and then still talk about those inequities, talk about the disparities, but know that the Black skin isn't a sentence. It's very complex, and it's not anything to do with a tragically flawed body.
Thank you, Dr. Williams, for ending on that and having a positive note that yes, we have come together today to really take a look at Black maternal health and the inequities and disparities, but also that's not all we are as a people, and that's not all our families that we serve and support, that we definitely need to have a positive outcome. And so thank you. I wanted to take this opportunity now to acknowledge our sponsors. So our sponsors for tonight's event was Community Doula Alliance, Community Doula Program, Lactation Educational Resources, Linn Benton Health Equity Alliance Coordinator, the NAACP and Corvallis and Albany branch, Samaritan Health Services, and Uplift Lab. So thank you everyone for coming. Thank you again to the panelists. It's been a great evening. I hope everybody learned a lot today. Thank you.
Thank you. It's been amazing. Thank you all, everybody. I know there was a question about contact information. It'll all be sent. Apparently, it'll be posted on the Uplift Lab website. So definitely connect if you're wanting to connect with any of us on the speakers offline. Definitely look out for that post on their website. And yeah, this was a wonderful conversation. I'm so grateful to have been a part of it and listen to y'all's powerful stories and truths. So thank you.
Thank you.
Thank you.